Hello, and welcome to the IRF and LTAC training, part 1. I'm Teresa Mata, and I will be presenting Social Determinants of Health and new revised items in sections A, B, and D. I've been a registered nurse for 29 years and have experience in direct patient care, education, nursing administration, quality improvement and measurement, as well as the development of post-acute care patient-resident assessment instruments. My experience includes inpatient care and long-term care facilities and assisted living, as well as a nurse consultant at the Centers for Medicare and Medicaid Services, assisting with the implementation of the IMPACT Act. Currently, I am a health research and evaluation associate at Apt Associates in Cambridge, Massachusetts. At the conclusion of this training, you should be able to discuss the social determinants of health, or SDOH, data elements, and their significance in the assessment process. Define and discuss the new revised non-SDOH data elements in section A, administrative identification information, as well as in section B, hearing, speech, and vision. You also should be able to summarize the implications for these data elements in your specific care setting. Let's take a look at the implications of these data elements in the inpatient rehabilitation facility, or IRF, and long-term care hospital, or LTAC settings, by reviewing the changes that have been made. The new SDOH data elements added for both IRF and LTAC are listed here and include A1005 ethnicity, A10100 race, A1100 language, which is new for IRF but revised for LTAC, A1250 transportation, B1300 health literacy, and D0700 social isolation. There are also new non-SDOH data elements for IRF and LTAC. These include A2121 through A2124, transfer of health information, A1990, patient discharged against medical advice, and this is new in LTAC only, B0200 hearing, and B1000 vision. Before we get into the actual section-by-section review, there are new data elements that have been added under the umbrella of social determinants of health. And we want to take a moment here to discuss what social determinants of health are. SDOH are the conditions in which people live, work, learn, and play, and they affect a wide range of health risks and outcomes. Several SDOH data elements added to the post-acute care, or PAC, assessment instruments conform to the 2011 Health and Human Services Data Standards. Capturing standardized SDOH data helps to understand factors at an individual, community, and population level, improve quality of care and health outcomes, document and track health disparities, allow for the comparison of SDOH data within and across PAC settings, and supports the collection and sharing of data across certification, policy, coordination agencies, and stakeholders. Let's start now by reviewing the SDOH data elements in sections A, B, and D. As reviewed previously, these are the 6 standardized SDOH patient assessment data elements in sections A, B, and D that we will be reviewing. Starting with section A, let's look at the intent of this section. In the IRF Patient Assessment Instrument, or IRF-PAI manual, it simply mentions that the intent of section A is to document information about the patient. In the LTAC Continuity Assessment Record and Evaluation Dataset, or LCDS manual, it further defines this section as collecting key information that uniquely identifies each patient, the LTAC in which the patient receives healthcare services, and the reasons for assessment. So the first SDOH data element that we will review is A1005 ethnicity. This is a snapshot of the data element, as you will see on the assessment instruments. When looking at the IRF-PAI, you'll see that both admission and discharge assessments are contained in one assessment instrument. The LCDS has 4 different time points, which are displayed in 4 different data sets: admission, planned discharge, unplanned discharge, and expired. When looking at the assessment instruments, you'll see that this particular data element can be found on page 3 of the admissions section of the IRF-PAI, and in the LCDS, it is on page 3 of the admission assessment. As you can see, ethnicity is a check all that apply data element that is conducted on admission only. We will discuss what this means when we review the coding instructions in a few moments. The rationale for collecting this new information on ethnicity is to improve understanding of and address ethnic disparities in healthcare outcomes. The way this data element is constructed is a 2-question check all that apply format. Both ethnicity and A1010 race data elements provide the data granularity that is important for documenting and tracking health disparities. Collection of ethnicity data is an important step in improving quality of care and health outcomes. Standardizing data across multiple PAC settings allows for the comparison of data within and across these settings. One thing to remember when collecting this data is that these ethnic categories are not used to determine eligibility for participation in any federal program. Here are the steps an assessor would use to complete this data element. The first thing an assessor should do is ask the patient to select that category or categories that most closely correspond to the patient's ethnicity from the list in A1005. Now, some people may be uncomfortable answering the ethnicity and race questions. So to allay any concerns, the assessor could introduce the ethnicity and/or race questions by saying, we want to make sure that all of our patients get the best care possible, regardless of their ethnic and or racial background. The respondent, which can be the patient or a proxy if the patient is unable to respond, should be offered the option of selecting one or more ethnic designations, because remember, this is a check all that apply data element. If neither the patient nor proxy is able to provide a response to this data element, you may use medical record documentation. Do not use a proxy response or medical record documentation if a patient declines to respond to this data element. Now that we've gone over the steps for assessment, let's look at the coding instructions for the ethnicity data element. As was mentioned previously, when looking at the snapshot of the data element, IRFs and LTACs will be completing this data element on admission. What this means is that they will complete this data element as close to the time of admission as possible. Again, this is a check all that apply data element. Of note, if the patient can provide a response, the assessor will check the box or boxes indicating the ethnic category or categories that were identified by the patient. In addition to the ethnic categories listed in this data element, there are 2 additional coding responses for when patients either are unable to respond or decline to respond. Code X is used if the patient is unable to respond. If a patient is unable to respond, a proxy may be used, or the assessor may look to see if there is any medical documentation that provides this information. If a response to this data element is determined via proxy or medical record documentation, the assessor would code the appropriate category or categories as well as checking code X. If the patient is unable to respond and there is no proxy or medical record documentation available to provide this information, the assessor is to check only code X and no other response. Code Y, patient declines to respond, would be used in cases where the patient declines to respond. Remember from the steps for assessment that if the patient declines to respond, you cannot use a proxy or medical record documentation to answer the question, even if there is a proxy and medical documentation that could provide this information. In this instance, only code Y would be checked. The next new SDOH data element is A1010 race. Here's the snapshot of the data element as it appears on page 3 of the IRF-PAI in the admission section and on page 4 of the LCDS admission assessment. As you can see here, there are 14 different race categories listed along with 3 other response choices. Like ethnicity, the race data element is a check all that apply data element collected only on admission. The rationale for collecting this new SDOH information on race is to improve understanding of and address racial disparities in healthcare outcomes. Like ethnicity, the race data element provides data granularity, which is important for documenting and tracking health disparities and conforms to the 2011 Health and Human Services data standards. The collection of race data is an important step in improving quality of care and health outcomes, and standardizing this data allows for comparisons across multiple PAC settings. Remember that the categories within this data element are not used to determine eligibility for participation in any federal program. The first step to collecting this information is for the assessor to ask the patient to select categories that most closely correspond to their race from the list in A1010. Again, there may be some who are uncomfortable with answering this question, so the assessor can use a similar statement to the one that we reviewed under ethnicity when asking the patient about their race. Since this is a check all that apply data element, the patient should be offered the option of selecting one or more racial designation. If a patient is unable to respond, a proxy may be used. If neither the patient nor a proxy are able to provide a response, the assessor may look to the medical record for documentation. However, if a patient declines to respond, neither a proxy response nor medical record documentation may be used. Coding instructions for the race data element are similar to the ethnicity data element in that this data element is completed on admission as close to the time of admission as possible. And again, it is a check all that apply data element. If the patient can provide a response, the assessor would check the appropriate box or boxes in the race category or categories identified by the patient. Similar to ethnicity, the race data element also provides a code X if the patient is unable to respond. This allows for either the use of a proxy or medical record documentation to provide this information for coding. If a response to this data element is determined via proxy or medical record documentation, the assessor would code the appropriate category or categories as well as checking code X. If the patient is unable to respond and there is no proxy or medical record documentation available to provide this information, the assessor is to check only code X and no other response. Similar to the ethnicity data element, in A1010 race, code Y, patient declines to respond, would be used in cases where the patient declines to respond. If the patient does decline to respond, you cannot use a proxy or medical record documentation to answer the question, even if there is this information available. In this instance, only code Y would be checked. Code Z, none of the above, is checked if the patient reports or it is determined via proxy or medical record documentation that none of the races listed in A1010 apply to the patient. The next SDOH data element is A1110 language. As was stated in the overview of data elements, this particular data element is new in the IRF-PAI, but is a revision in the LCDS. Previously in the LCDS, the information now seen in A1110B, do you need or want an interpreter to communicate with the doctor or healthcare staff, used to be labeled as A1110A. However, when reviewing this data element for standardization across all PAC settings for better logical flow, the information was aligned across all assessment instruments to what is seen here, with A1110A recording the preferred language of the patient and A1110B recording whether the patient needs or wants an interpreter. Like the prior two data elements, language is collected only on admission as close to the time of admission as possible. And here you see the snapshot of the data element as it appears in the IRF-PAI on page 4 of the admission section and in the LCDS on page 4 of the admission assessment. Noted here in the item rationale, the new and revised language in the IRF-PAI and LCDS manuals state that the language barriers can lead to social isolation, depression, and patient safety issues, as well as potential interference with accurate assessment of the patient. As we are reviewing the steps for assessment related to A1110 language, you'll see blue text and blue text that is stricken out. The blue text includes new language, and the text that is stricken out denotes text that has been removed from the LCDS manual. Remember that all of this is new for the IRF-PAI. To complete this data element, the assessor will ask the patient for their preferred language. This response will be entered into the text fields provided in A1110A. What is your preferred language? Next, the assessor will ask the patient if they need or want an interpreter to communicate with the doctor or healthcare staff. This response is a simple no, yes, or unable to determine. If the patient or an interpreter, if one is used, is unable to respond to either question in A1110A or B, a proxy response is permitted. If neither the patient nor a proxy is able to provide a response to either question in A1110A or B, medical record documentation may be used to answer these questions. The coding instructions for both the IRF and LTAC include the completion of this data element on admission as close to the time of admission as possible. For LTACs only, there is an additional statement in the LCDS manual that refers assessors back to the reason for assessment data element A0250. When an LTAC assessor codes A0250 as 01, this denotes that the assessment being completed is an admission assessment. It's just another way to say that this data element is completed on admission. Let's look more specifically at A1110A. What is your preferred language? For A1110A, the assessor is to enter the preferred language that the patient primarily speaks or understands. If the patient or any available resource cannot or does not identify preferred language, the assessor should enter a dash symbol in the first text box. A dash indicates no information. And although a dash is an acceptable response for this data element, CMS expects dash use to be a rare occurrence. For A1110B, do you need or want an interpreter to communicate with a doctor or healthcare staff? Code 0, no, if the patient indicates that they do not need or want an interpreter to communicate with the doctor or healthcare staff. If the patient is unable to indicate the need or want of an interpreter, proxy input may be used. If the patient is unable and a proxy response is not available, then medical record documentation may be used to answer this question. The assessor would choose code 1, yes, if the patient indicates the need or want of an interpreter to communicate with the doctor or healthcare staff. Similar to A1110A, if the patient is unable to indicate the need or want of an interpreter, a proxy may be used. And if the patient is unable and a proxy response is unavailable, medical record documentation may be used. There is an additional response available, code 9, unable to determine. If no source can identify whether the patient wants or needs an interpreter, the assessor would enter code 9 as the response to this data element. And here's a coding tip for this data element. If a person reports that their preferred language is American Sign Language, this information can be entered in A1110A. What is your preferred language? And this is the final SDOH data element in section A that we will be reviewing. A1250, transportation. Again, here's a snapshot of the data element as it appears in the assessment instruments. A1250 transportation is completed on both admission and discharge and is a check all that apply data element. In IRF-PAI, you can see this data element on page 4 of the admission section and page 18 of the discharge section, and in the LCDS on page 4 of both the admission and planned discharge assessments. This copyrighted data element from the National Association of Community Health Centers was adapted for use by CMS. The rationale for collecting this information is that access to transportation for ongoing healthcare and for medication access is essential to effective care management. Understanding patient transportation needs can help organizations assess barriers to care and facilitate connections with resources available in their community. In order to complete this data element, the assessor should ask the patient the following 2 questions. In the past 6 months to a year, has lack of transportation kept you from medical appointments or from getting your medications? And in the past 6 months to a year, has lack of transportation kept you from non-medical meetings, appointments, work, or from getting things that you need? The patient should be told that they can respond yes to one or both of these questions if applicable. If the patient is unable to respond, a proxy response may be used. If neither the patient nor a proxy response is able to provide the information to answer these questions, medical documentation may be used. And if the patient declines to respond, the assessor cannot code this data element based on proxy input or medical documentation. Let's review the coding instructions. This data element is completed on admission as close to the time of admission as possible, and it is also completed on discharge within 3 days of discharge. This is also a check all that apply data element. The assessor will check code A if the patient indicates that lack of transportation has kept them from medical appointments or getting medications, or choose code B if the patient indicates that lack of transportation has kept them from non-medical meetings, appointments, work, or from getting things that they need. If the patient indicates that a lack of transportation has not kept them from medical appointments, getting medications, getting to non-medical meetings, appointments, work, or getting things that they need, the assessor will check code C, no. If the patient is unable to respond, this data element also provides code X. Recall that this code allows for the use of a proxy or medical record documentation to complete the data element. If code X is chosen because a proxy or medical record documentation provides the necessary information to respond, the assessor would check all boxes that apply, including code X. If the patient was unable to respond and there were no resources that provided the necessary information, only code X would be checked. Code Y, patient declines to respond, would be used in cases where the patient declines to respond. If the patient does decline to respond, you cannot use a proxy or medical record documentation to answer the question, even if these exist. In this instance, only code Y would be checked. We are now leaving section A and moving into the SDOH data element found in section B, health literacy. This is the snapshot of the health literacy data element B1300. This data element is completed on admission and discharge. It appears in the IRF-PAI on page 5 of the admission section and page 19 of the discharge section, and in the LCDS on page 6 of both the admission and planned discharge assessments. Looking at the rationale for the collection of this data, we see that similar to language barriers, low literacy can interfere with communication between the patient and provider. It can also affect the ability of patients to understand and follow treatment plans, including medication management. All of this leads to lower levels of knowledge of health, worse outcomes, the receipt of fewer preventative services, and higher medical costs, as well as the rate of emergency department use. Assessing for health literacy will facilitate better care coordination and discharge planning and help providers understand how their patients best learn information and how to support them in managing their health conditions. Here we have a definition of health literacy. It is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Because this data element is intended to be answered solely by the resident, that is via self-report, no other source may be used to identify the response to this data element. In order to complete this data element, the assessor will ask the patient, how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy? The coding instructions for health literacy inform the assessors in IRFs and LTACs that this data element is to be completed on admission and discharge as close to the time of admission as possible and within 3 days of discharge. For LTACs only, there is further information that this data element is completed when A0250, the reason for assessment, is coded as 01, which means the admission assessment, or is coded as 10, which means planned discharge. In response to the question, how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy, assessors will enter code 0, never, if the patient indicates never needing help reading instructions, pamphlets, or other written materials from doctors or pharmacies. Code 1, rarely, will be used if the patient indicates rarely needing this help. They'll enter code 2, sometimes, if the patient indicates sometimes needing help reading instructions, pamphlets, or other written materials from doctors or pharmacies. Or they'll enter code 3, often, if the patient indicates often needing this help. Code 4 will be used if the patient indicates always needing help reading instructions, pamphlets, or other written materials from doctors or pharmacies. The assessor would code 7, patient declines to respond, if the patient declines to respond to this data element. Or they could enter code 8, patient unable to respond, if the patient was unable to respond. And here's the final SDOH data element that we will review, social isolation. And here's a snapshot of the social isolation data element, which is also completed on both admission and discharge. This data element appears in the IRF-PAI on page 8 of the admission section and page 21 of the discharge section, and in the LCDS on page 9 of both the admission and planned discharge assessments. Social isolation tends to increase with age. It is a risk factor for physical and mental illness and a predictor of mortality. Assessing social isolation can facilitate the identification of patients who may benefit from engagement efforts and improve quality of life. Programs to increase social engagement of patients should be designed and implemented while also taking into account individual needs like disability or language and preferences such as cultural practices. Here's a definition of social isolation. Social isolation refers to an actual or perceived lack of contact with other people, such as living alone or residing in a remote area. Note that like the health literacy data element, D0700 social isolation is intended to be completed via patient self-report. Therefore, no other source may be used to identify the response. In order to conduct this assessment, the assessor will ask the patient the following question. How often do you feel lonely or isolated from those around you? The coding instructions for social isolation mirror that of health literacy data element. Specifically, that this data element is to be completed on admission and discharge as close to the time of admission as possible and within 3 days of discharge. For LTACs only, there is a further information that this data element is completed when A0250, reason for assessment, is coded as either 01, which means the admission assessment, or when A0250 is coded as 10, which means on planned discharge. In response to the question, how often do you feel lonely or isolated from those around you? Assessors will enter code 0, never, if the patient indicates never feeling lonely or isolated from others. Code 1, rarely, if the patient indicates rarely feeling this way. Code 2, sometimes, if the patient indicates sometimes feeling lonely or isolated from others. The assessor would choose code 3, often, if the patient indicates often feeling this way. Code 4, always, if the patient indicates always feeling lonely or isolated from others. The assessor would enter code 7, patient declines to respond, if the patient declines to respond to this question, or code 8, if the patient is unable to respond to this question. Now let's move on to a few standardized patient assessment data elements that are not considered under social determinants of health. The first non-SDOH data element we're going to look at is A1990, patient discharged against medical advice. Since this data element is only found in the LCDS, this information is only pertinent to LTACs. Here is a snapshot of the patient discharged against medical advice data element, which is found on page 4 of the LCDS unplanned discharge assessment. This data element is collected because it allows the identification of unplanned discharges that occurred against medical advice. To be discharged against medical advice means that the patient elected to leave the facility prior to the physician's recommendation for discharge. This is important to collect because discharges against medical advice put patients at increased risk of adverse clinical outcomes and are a predictor for 30-day readmissions. There is only one step for assessment in this data element. When a patient leaves against medical advice, before coding this data element, the assessor needs to confirm that the patient's medical record does not contain a discharge order from the managing physician. Again, this data element is only completed on the unplanned discharge assessment, denoted when A0250, reason for assessment, is coded as 11 on the LCDS. The assessor would enter code 0, no, if the patient was not discharged against medical advice. If the patient had an unplanned discharge from the facility and there was not an order from the managing physician recommending discharge from the facility in the patient record, the assessor would enter code 1, yes, the patient was discharged against medical advice. Although it is not required, facilities may elect to use their own discharge against medical advice form to be signed by the patient and/or family. The next non-SDOH data elements we will be reviewing are actually a series of data elements under the title of Transfer of Health Information. These data elements include A2121 through A2124. Let's review the terms that are important for the assessor to understand when completing these data elements. At the time of discharge means as close to the actual time of discharge as possible. This time may be based on facility, state, or federal guidelines for data collection at discharge. Current reconciled medication list refers to the current list of patients' medications that were reconciled by the facility prior to the patient's discharge. Means of providing a current reconciled medication list refers to the ways a reconciled medication list can be provided at the time of discharge. This can include both active and passive means. Active means could be via email, electronically, or verbally. Passive means could be via upload to a common electronic health record, or EHR, or provider portal. An EHR, or electronic medical record, or EMR, is an electronic version of a patient's medical history maintained over time. A portal is a secure online website that gives providers, patients, and others authorized convenient 24-hour access to personal health information from anywhere that has an internet connection. You can find additional information related to EHRs, EMRs, and portals in your respective guidance manuals. So let's start with A2121, provision of current reconciled medication list to subsequent provider at discharge. Here's the snapshot of A2121 as it appears in the IRF-PAI on page 18 of the discharge section and in the LCDS on page 5 of both the planned and unplanned discharge assessments. Note that this data element is completed on discharge only, which, as if you remember from our review of important terms, means that this is to be completed as close to the actual time of discharge as possible. The rationale for collecting this data is that the transfer of a current reconciled medication list at the time of discharge can improve care coordination and quality of care, can help subsequent providers reconcile medications, and may mitigate adverse outcomes related to medications. It is critical that communication of an accurate reconciled medication list from one healthcare setting or provider to another is accomplished, as it ensures safe and effective transitions of care. In order to complete this data element, assessors need to determine if the patient was discharged to one of the subsequent providers listed, which we'll review in the next couple of slides. If the patient was discharged to one of these providers, the assessor needs to determine if the facility provided a current reconciled medication list to the patient's subsequent provider. For IRFs, the assessor will review the response provided in the IRF-PAI data element number 44D, patient's discharge destination living setting, found on page 2 of the IRF-PAI, to determine if the patient was discharged to a subsequent provider. As you can see from the title of this slide, this subsequent provider list applies not only to A2121, but applies to A2122, which refers to the route through which this information was communicated to the subsequent provider. We'll review A2122 after we complete our review of A2121. For LTACs, the assessor will review the responses provided in the LCDS data element number A2105, discharge location, which can be found on page 5 of the planned discharge assessment and on page 4 of the unplanned discharge assessment. This will be used to determine if the patient was discharged to a subsequent provider. Again, this subsequent provider list applies to both A2121 and A2122. Here are the coding instructions for IRF and LTAC. For IRF, this data element must be completed within 3 days of discharge as close to the time of discharge as possible. And for LTACs, this is completed as close to the time of discharge as possible, only on planned and unplanned discharge. That is, if A0250 reason for assessment is coded either as a 10 or 11, respectively. Based on the response seen in D44 for IRFs or A2105 for LTACs, the assessor would code 0 no if at discharge to a subsequent provider, the facility did not provide the patient's current reconciled medication list to that subsequent provider, or the patient was not discharged to a subsequent provider. If the assessor chooses code 0 no, they would move ahead to complete A2123, provision of reconciled medication list to the patient at discharge. Again, based on the subsequent provider list in D44 for IRFs or A2105 for LTACs, if at discharge to a subsequent provider, the facility did provide that current reconciled medication list to the subsequent provider, the assessor would code 1 yes, and then move on to complete the next data element, A2122, route of current medication list transmission to subsequent provider. Here are a couple of coding tips related to A2121. Patients may receive care from other providers after discharge from the facility that are obviously not listed as a subsequent provider in D44 or A2105, such as primary care providers, other outpatient providers, and treatment centers. It's important to note that these locations are not considered to be subsequent providers for the purposes of coding this data element. You just need to pay attention to the list as provided in the manual and cross-check that list with the responses in D44 or A2105 in the IRF-PAI and/or LCDS, respectively. The facility should be guided by current standards of care and any applicable regulations and guidelines, such as conditions of participation, in determining what information should be included in a current reconciled medication list. There is additional guidance that can be found in your setting-specific manual, so please take some time to review this information. But here's a short summary of some of the key elements that may exist on a reconciled medication list. These include, but are not limited to, demographic information, allergies, adverse reactions, special instructions, the purpose or indication for use of the medication, and current prescribed or over-the-counter medications. While this information serves as guidance, the completeness of the medication list is left to the discretion of the provider. So where can you find information related to medication lists? Documentation sources for reconciled medication list information can include electronic and/or paper medical records. Some examples of such records are medication administration records, physician orders, discharge summary records, and home medication lists. Here's a snapshot of the next data element that we will be reviewing. This is A2122, route of current reconciled medication list transmission to subsequent provider, as it appears in the IRF-PAI on page 18 of the discharge section and in the LCDS on page 5 of both the planned and unplanned discharge assessments. Remember that you're only going to complete this data element if the response to A2121 was code 1, yes. That is, a current reconciled medication list was provided to a subsequent provider. Note that for this data element, you're going to check all that apply, and it is completed on discharge only, as close to the actual time of discharge as possible. I want to stop here for a moment and acknowledge that I'm presenting this information in sequential order, unlike how you will see it presented in the IRF-PAI and LCDS guidance manuals. I'll be presenting A2122 in full, and later in the presentation, I will only very briefly summarize a similar data element, A2124, route of current reconciled medication list to patient, as the routes of transmission are the same for both data elements. The rationale for collecting the route of transmission in A2122 is to monitor how medication lists are transmitted at discharge. The assessor will identify all routes of transmission that were used to provide the patient's current reconciled medication list to that subsequent provider. Similar to A2121 for IRF, this data element must be completed within 3 days of discharge, as close to the time of discharge as possible. And for LTACs, this is completed as close to the time of discharge as possible, only on planned and unplanned discharge. That is, if A0250 reason for assessment is coded either as a 10 or 11, respectively. The guidance in the LCDS manual further states to select the response codes that correspond to the routes of transmission used to provide the medication list to the subsequent provider. In order to select the appropriate codes that correspond to the routes of transmission used, we need to understand what each of these response codes mean. The assessor will check A2122A, electronic health record or EHR, if the facility has an EHR, and use it to transmit or provide access to the reconciled medication list to a subsequent provider. This can happen when both the discharging entity and the subsequent provider have direct access to a common EHR. It's important to note that checking this route doesn't mean that there has to be any kind of confirmation that the subsequent provider has access to the EHR to obtain the medication list. We're just documenting here that the reconciled medication was sent to the subsequent provider via this route. If the reconciled medication list was transmitted via a health information exchange or HIE, the assessor would check A2122B. An HIE is an organization to which a facility may participate, which allows for an electronic change of data with other authorized entities. In this case, our subsequent provider. If the reconciled medication list was communicated verbally, either in person, by telephone, or video conference to the subsequent provider, the assessor would check A2122C, verbal. Finally, if the reconciled medication list was transmitted to the subsequent provider using a paper-based method like a printout, fax, or electronic fax, the assessor would check A2122D, paper-based. And if this information was transmitted via other methods not listed here, the assessor would check A2122E, other methods. Examples of other methods might be via text, email, or a CD. Here are some coding tips to consider for A2122. The route of transmission usually is established with each subsequent provider, depending on how they're able to receive information from your facility. The route or routes may not always be documented in the patient's record. It will be helpful to understand and document how your facility typically transmits information to each subsequent provider at discharge to prepare for coding this item. Remember that more than one route of transmission may apply, and this is a check all that apply data element. So it's perfectly fine to see multiple responses checked off. Here's the next data element in the series of transfer of health information, A2123, provision of current reconciled medication list to patient at discharge. And here's a snapshot of A2123 on the IRF-PAI. You'll find this data element on page 18 in the discharge section. As with the other transfer of health information data elements, this is only collected on discharge, as close to the time of discharge as possible. And here are the snapshots of A2123 as seen on page 5 of both the planned and unplanned discharge of the LCDS. The only difference between the planned and unplanned discharge on the LCDS for data element A2123 is the skip pattern related to code 0, no. On the planned discharge, if the response to A2123 is code 0, no, the assessor should move on to complete B0100, comatose. On the unplanned discharge assessment, if the response to A2123 is no, the assessor should move on to complete C1310, signs and symptoms of delirium. For both the planned and unplanned discharge, A2123 is to be completed as close to the time of discharge as possible. The rationale for collecting this data is that communication of medication information to the patient at the time of discharge is critical to ensuring safe and effective discharges. It also improves care coordination, quality of care, aids in medication reconciliation, and may mitigate adverse outcomes related to medications. It is recommended that a reconciled medication list, if provided to the family, patient, and/or caregiver, be provided in a consumer-friendly, plain language way so that it is understandable. You can find more information on plain language in your respective guidance manuals. The first step the assessor will complete is to determine if the patient was discharged to a home setting or a not listed location. Again, this will be based on the responses in the discharge location items on both the IRF-PAI and LCDS. And remember, those data elements for the IRF-PAI is D44, and for the LCDS, it's A2105. Home setting is coded as 01 on both the IRF-PAI and LCDS. And the not listed location is coded as 99 on both the IRF-PAI and LCDS. If the patient was discharged home or to a not listed location, the assessor then needs to determine whether at the time of discharge, the facility provided the patient, family, and/or caregiver with the current reconciled medication list. Coding instructions for A2123 are similar to what we've been talking about. For the IRF, it must be completed within 3 days of discharge, as close to the time of discharge as possible. For LTAC, it is to be completed as close to the time of discharge as possible, only on the planned or unplanned discharge assessments. That is, if A0250 equals 10 or 11, respectively. The assessor would code 0 no if a patient was discharged home or to a not listed location, and the facility did not provide the patient's current reconciled medication list to the patient, family, and or caregiver, or the patient was discharged to a subsequent provider. If when the patient was discharged home or to a not listed location and the facility did provide a current reconciled medication list, the assessor would code 1 yes, and then move to complete the next data element, A2124, route of current reconciled medication list transmission to patient. Here's a coding tip related to completing A2123. As you can see here, although written a little differently, home setting is essentially the same on the IRF-PAI and LCDS. Not listed is the same for both assessment instruments and is code 99. For A2123, the recipient of the current reconciled medication list can be provided to the patient, family member, and or caregiver. It is not necessary to provide the current reconciled medication list to all of these recipients in order to code 1 yes. Finally, let's look at A2124, route of current reconciled medication list transmission to patient, which is the last in the series of the transfer of health information data elements. Here's the snapshot of A2124 as seen on page 18 of the IRF-PAI discharge section and on page 5 of both the planned and unplanned discharge in the LCDS. This data element is completed only on discharge and as close to the time of discharge as possible. As was mentioned at the beginning of the presentation on this series of data elements, the response codes A through E for A2124 are the same as in A2122. In A2124, the rationale, coding instructions, and tips are the same as what was reviewed for A2122. The step for assessment in A2124 is the same as what we've reviewed in A2122, except that it pertains to identifying all routes of transmission used to provide the patient's current reconciled medication list to the patient, family, and or caregiver, rather than the subsequent provider. Since we are not fully reviewing this particular data element in the interest of time, we ask that you please refer to your setting-specific manual for further details. The next new data elements we are reviewing can be found in section B, which includes data elements related to hearing, speech, and vision. The two new data elements being added to the IRF-PAI and LCDS are B0200 hearing and B1000 vision. These data elements can be seen on page 5 of the IRF-PAI admission section and on page 6 of the LCDS admission assessment. These data elements are completed on admission only. Even though hearing and vision are new data elements to both the IRF-PAI and LCDS, both assessment instruments have additional data elements in this section related to communication. Therefore, the rationale for section B was updated to include information related to hearing and vision. So now the intent of these items reads that the intent is to document the patient's ability to hear with assistive devices if they are used, understand and communicate with others, in the patient's ability to see objects nearby in their environment. First, we'll review B0200 hearing. And again, here is the snapshot of B0200. The rationale for collecting this data is that problems with hearing can contribute to sensory deprivation, social isolation, and mood and behavior disorders. Unaddressed communication problems related to hearing impairment can be mistaken for confusion or cognitive impairment. In order to complete this assessment, the assessor needs to ensure that the patient has their normal hearing appliance available if they use one. A person could be using a hearing amplifier or microphone and headphones or a hearing aid. So be sure that you know what appliance is used, if any, and ensure that it is operational. The assessor would then interview the patient and ask about hearing function in different situations, like when talking to visitors, staff, or family members, using the telephone, watching television, or participating in a group discussion. The assessor should also observe the patient during regular verbal interactions that occur throughout the day. When thinking about assessing a patient's hearing ability, consider how you best communicate with the patient. You may need to speak more clearly or raise your volume, speak more slowly, or use gestures. The patient may also need to see your face, especially if they read lips, to understand what you're saying, or you may need to move to a quieter area. Be sure to review the medical record for any documentation of a hearing issue and consult the patient's family, caregivers, direct care staff, and other staff or specialists as needed. For both IRF and LTAC, this data element is completed only on admission and as close to the time of admission as possible. For LTAC, there is an additional information that refers to the fact that this data element is completed only when A0250 reason for assessment is 01, meaning admission. If the assessor determines that the patient hears and has no difficulty in hearing normal conversation and social interactions, listening to the television, radio, using the telephone, etc., they should code 0 adequate. If the patient has minimal difficulty, meaning that they have difficulty in some environments, that is, if the setting is noisy or if the person speaking to them speaks softly, but the patient's hearing is adequate after environmental adjustments are made, like reducing background noise or moving to a quieter area, the assessor should code 1, minimal difficulty. The assessor would use code 2, moderate difficulty. If in order for the patient to hear, people have to adjust their own volume, speak distinctly in order to be heard, or perhaps face the resident when speaking. Use code 3, highly impaired, if there is an absence of useful hearing. What this means is that the patient would only hear some sounds and frequently fails to respond or comprehend the speaker, even when maximum accommodations, such as increasing volume, speaking distinctly, or positioning face-to-face with the patient are used. Here's a coding tip related to hearing. If a patient is unable to respond to a standard hearing assessment due to cognitive impairment, they will require an alternate assessment methods, such as observing them in their normal environment. Pay attention to cues, such as whether the resident turns their head when a noise is made at a normal level, or if the patient seems to respond only to specific noises in a quiet environment, or responds only to loud noises, or doesn't respond at all. And this is the last data element we will be reviewing today, B1000 vision. And again, here's a snapshot of this data element. The rationale for collecting data on a person's vision is that a person's reading vision often diminishes over time. If left uncorrected, vision impairment can limit everyday activities that the patient normally would enjoy, like reading newspapers or books, correspondence, or even participation in activities. It can also limit the ability to manage personal business and sign forms. Moderate, high, or severe vision impairment can contribute to sensory deprivation, social isolation, and depressed mood. In terms of assessing vision, it is important to have adequate lighting, sufficient enough that a person with normal vision is comfortable seeing fine detail. In order to assess vision, the assessor should ask family, caregivers, and/or direct care staff over all shifts if possible about the patient's usual vision patterns. Consider questions such as whether the patient is able to see newsprint, menus, or greeting cards that they may receive. Then ask the patient about the visual ability. Test the accuracy of these findings by ensuring that the patient's customary visual appliance for close vision is available and used, like eyeglasses or a magnifying glass. Ensure adequate lighting. Ask the patient to look at and read regular sized print in a book or newspaper, starting with the headlines and ending with the smallest print. If the patient is unable to read a newspaper, provide material with larger print, like a flyer or a large print book. If a patient is unable to read aloud due to aphasia or perhaps illiteracy, the patient should be tested using other means, such as, but not limited to, substituting numbers or pictures for words that are displayed in appropriate print size, like regular print in a book or newspaper. For this data element, the same coding instructions apply as they did for hearing. For IRF and LTAC, this data element is completed only on admission and as close to the time of admission as possible. For LTAC, there is additional information that refers to the fact that this data element is completed only when A0250 reason for assessment is coded as 01 admission. Once the assessor has completed the visual test, they should choose one of the following response codes that correspond to the results of their findings. The assessor would code 0 adequate if the patient sees fine detail, including regular print in newspaper and books. Code 1 impaired if the patient sees large print, but not regular print in newspapers and books. Code 2 moderately impaired if the patient has limited vision and is not able to see newspaper headlines, but can identify objects nearby in their environment. The assessor should code 3, highly impaired, if the patient's ability to identify objects nearby in their environment is in question, but the patient's eye movements appear to be following objects, especially people walking by. Or code 4, severely impaired, if the patient has no vision, sees only light, colors, or shapes, or does not appear to follow objects with their eyes. And finally, here are some coding tips for B1000 vision. Be aware that some patients have never learned to read or may be unable to read in English. In such cases, ask the patient to read numbers, such as dates or page numbers, or to name items in small pictures. Be sure to display this information in 2 sizes equivalent to regular and large print. If the patient is unable to communicate or follow your directions for testing vision, observe the patient's eye movements to see if their eyes seem to follow movement in objects. Though these are gross measurements of visual acuity, they may assist you in assessing whether or not the patient has any visual ability. For patients who appear to only follow movement in objects, choose code 3, highly impaired. So to summarize, we've reviewed the new SDOH data elements in sections A, B, and D, which were added to the IRF-PAI and LCDS, and a data element that was revised to achieve data element standardization. We also reviewed some non-SDOH data elements that were added to the IRF-PAI and LCDS. In closing, if you would like to submit a question regarding this presentation, please send it to pactraining@econometricainc.com by June 3rd. As a reminder, a practice coding workshop will be held in June, and we do encourage you to attend. Select questions will be answered in a Q&A session during this June 2022 virtual live event. Thank you for reviewing this presentation, and we look forward to your attendance at the coding workshop.